Hello, I'm D. Scott Smith, and I am recording for the Invisible International, and I'd like to thank Monte Calvo Foundation for supporting this initiative. Today, I'm going to speak about Rocky Mountain spotted fever and go through all of the clinical basics for this disease. I have no disclosures, no conflicts for this topic. I consult for Seqirus, Valneva, and Serimune. The objectives for the CME include to define Rocky Mountain spotted fever and its causative agent, to discuss the epidemiology of Rocky Mountain spotted fever in the US, including risks and seasonality, and explain who will most likely encounter this disease and list the differential diagnosis. Furthermore, we'll explore the latest diagnostic tools for Rocky Mountain spotted fever, including serologic tests and molecular assays, and we'll outline the best clinical treatment strategies for Rocky Mountain spotted fever. First of all, the epidemiology. The causative agent is Rickettsia rickettsiae, and Rocky Mountain spotted fever is the most severe and lethal of all of the spotted fevers. And in the US, there are 3 different tick species that can transmit it: the American dog tick, or Dermacentor variabilis, Rocky Mountain wood tick, or Dermacentor andersoni, and the brown dog tick, which is Rhipicephalus sanguinus. And the causative agent, again, is Rickettsia rickettsiae, which is a small gram-negative rod-shaped intracellular bacteria. And here you can see it's depicted in an immunohistochemical stain showing endothelial cells. So it's an intracellular organism, and this happens to be in cells from a lung specimen in a fatal case of Rocky Mountain spotted fever. The epidemiology also is important to note that it's increasing in the US over the last 2 decades. And I think you can appreciate it's going up almost every year since the year 2000, according to reportable data to the Center for Disease Control. More about the epidemiology, I'd like you to understand where the ticks come from and how they interface with humans and human activity. This is a very interesting graphic showing almost 100 years of tick data, where Dermacentor andersoni is in the United States. And so the brown counties are indicating the presence of the vector. And this kind of data has been transformed into more easily understood mapping, with the yellow in these maps of each of the dermacenters that I'll show you. So the Rocky Mountain wood tick, or Dermacentor andersoni, is found pretty much in the area depicted in yellow here. And there's a picture of the tick as well. And this particular tick, Dermacentor andersoni, transmits not only Rocky Mountain spotted fever, but also Colorado tick fever and tularemia. So not just a bacteria, rickettsia, but also a virus and another type of bacteria. This is the other Dermacentor variabilis and Dermacentor similis in these 2 different zones. And you can appreciate pretty much the whole United States is covered with all of these 3 species of Dermacentor tick. There's also another 4th species of tick, the brown dog tick, or Rhipicephalus sanguinus, that's pretty much distributed throughout the whole United States and internationally as well. So the geography, contrary to the name of this disease, is most represented in the southeastern and south central U.S. So some of the states, North Carolina, Tennessee, Oklahoma, are much more affected than others. And this picture of the U.S. With a heat map coloring, so the darker states representing higher transmission, really illustrates differences across the United States. And so it's not Rocky Mountain area so much as the Southeast. So looking at the rates, and I chose 5 states, each illustrating a slightly different color. Arkansas here has 55.8 cases per million population. So the rate is highest in those darker states in the Southeast. And then Montana, where this disease was originally discovered in the Bitterroot Valley, has a much lower rate, as do all of these states in the Rocky Mountains. And New York, which is where Lyme disease is transmitted at very high rates, you can see has a low rate of Rocky Mountain spotted fever. Obviously, it's a different tick as well. And Colorado, just to point out, the center of the Rocky Mountains has one of the lowest rates, and California, the lowest rate. And our case is going to come from there. So I'll show you that in a moment. So again, mapping where ticks are and how they interface with humans is really important. And this study illustrates how variables such as land cover, elevation, precipitation, vapor pressure, et cetera, enable us to understand where ticks are, but also human population interfacing with those environments where ticks thrive also helps predict where the disease can most likely be transmitted. And this is described with this, this type of mapping. So other factors about epidemiology, spending time in the outdoors and tick habitats in wooded areas and tall grass increases risk for getting Rocky Mountain spotted fever. Occupations with outdoor exposure, obviously landscaping, forestry, and those types of occupations would put somebody at higher risk. There's another factor, seasonality, which changes risk across the year. Spring and summer months, when tick activity is highest, is the most June and July are the most prevalent months for transmission of Rocky Mountain spotted fever. And this study looked across 4 years and averaged the number of cases to illustrate June and July are the highest months where Rocky Mountain spotted fever is transmitted to humans. This is another very interesting graph, again, across 100 years, looking since the 1920s at the incidence per million population. And you can see what was shown in the earlier CDC graphic of the year 2000 to 2020 in the red line, cases really dramatically going up by rate. And then the case fatality, interestingly, has gone down significantly in the 40s and 50s when antibiotics were introduced, but also again later after 2000. And that later decrement in case fatality is likely because the definition of the disease changed to lump together other spotted fevers with Rocky Mountain spotted fever, so that it appears, but it's not entirely specific for Rocky Mountain spotted fever fatality, because they lump them together. So just getting a little bit more detailed about who is at risk for tick bites and tick-borne diseases. Well, anyone living, working, or recreating in forested, brushy, or edge habitats. And so if you're gardening or have a yard near this area where ticks thrive, you'll be at a higher risk. Man-made trail systems, hunting, trails used by animals, so you're exposed to ticks that may drop off of deer, camping in campgrounds in wooded and brushy areas, and working out in the forested areas as well will put those in contact at higher risk for Rocky Mountain spotted fever. This is another recent study showing neglected tropical diseases are now happening in the United States, California in particular, and this study looked at a 40-year review of Rocky Mountain spotted fever in California specifically and how it's changed over the years. This graphic also gives us a sense of the different ticks that transmit different tick-borne diseases since 1908, when the first disease, rickettsia, was described, and Rocky Mountain spotted fever and all the other related diseases in brown, you see here, which are dermacenter species, were first described. So Ixodes, as you see in green, has a variety of tick-borne diseases as well. But I think this just gives a little bit of perspective to the longevity of this disease and how we've managed it over the last century. And many new diseases have been discovered. Initially, this was a very difficult disease to manage. It was being observed in the Bitterroot Valley in Montana, and people were dying spectacular deaths, probably 80% case fatality rates with these spotted rashes and high fevers and terrible headache and imminent demise. So let's just take a look at the clinical presentation. So the early illness in days 1 to 4, generally a fever, headache, gastrointestinal symptoms, and abdominal pain are features, in addition to things that are like flu, so myalgia, but also typically a rash, and the rash usually comes up about 2 to 4 days after the onset of the fever, and then edema around the eyes and on the back of the hands. And this photo of a child with that initial rash is what was typically described in early cases before diagnostics were available. Later in the illness, day 5 and beyond, there can be altered mental status, coma, cerebral edema, and respiratory compromise. Again, the endothelial cells are involved, and it's an intracellular infection that leads to this pathophysiology that can result in necrosis and sometimes requiring amputation. So it's a multi-organ system insult involving the CNS and often renal failure as well. And notice also in this picture that the palmar surface is involved, and that's not too common for many spotted fever diseases. This is a differential of Rocky Mountain spotted fever, and I've got the tick-borne diseases listed in the left column here: Lyme disease or lichiosis, babesiosis, anaplasmosis, tick fever, tularemia. And you can see there are a variety of both viral, bacterial, and parasitic diseases, all related to ticks in the US. And then in the other column are just other viruses and bacteria that could be confused. And meningitis is probably the top one that we would be thinking of first. And it could present similarly with a rash, high fevers, and headache. And that's what would prompt often a meningitis workup and a lumbar puncture, that sort of thing. But if you have these spots on the hands, for instance, on the palms or the soles of the feet, you should also be thinking of Rocky Mountain spotted fever. And this is the most recent publication that really goes into the detail about diagnosis and management of tick-borne rickettsial diseases, in particular Rocky Mountain spotted fever. And this is from the CDC in 2016 and is a really good 48-page summary of what we know and what to do. So with that in mind, and before going into the diagnostics and the treatments, I just want to present a case that really challenged us in California, where this gentleman presented in San Mateo County. So he has agreed to share his story, and is very challenging for us because obviously it's a rare disease, but with the long list of things that were sent on his blood, we managed to make the diagnosis. So he was a 52-year-old man. He came to the emergency department in mid-June, and he was found by his girlfriend in his garage, confused. 4 days previously, he had really had a severe headache, and in the emergency department, he had altered mentation, hallucinations, and fever. He was admitted thinking of meningitis, and LP was done, and he developed a diffuse macular rash on his trunk and extremities 3 days later. He was reported by his friends to have camped in Butano State Park 2 weeks prior to admission, and that was in late May. This was in San Mateo County, California, and he had no history of tick bites that he was aware, or outside travel, so he hadn't been beyond San Mateo County in California. This is my family, and in Butano State Park, a favorite place, a beautiful place to spend time in the outdoors and camp. And here's a picture as he became confused and lapsed into a coma, and he required intubation and ICU care. And you can appreciate on his abdomen here, maculopapular rash. It was also involving his palms. You can see he was incontinent. He happened to be intubated and was unconscious for quite some time. A variety of infectious disease tests, including West Nile virus, Parvo B, Q fever, which is Coxiella burnetii, HSV PCR of his CSF was done, and Rickettsia typhi and Rickettsia were sent. And the acute values were positive, but requisite to making the diagnosis, convalescent serology also must be sent, and that actually even bumped up further, showing an IgG up to 1 to 16,000. So definitely a positive signal there, and this cinched the diagnosis. Luckily, after a rocky course, almost 2 weeks in the hospital, he did receive doxycycline. He was extubated. He regained baseline mental status, and he improved and was discharged. Here he is giving the victory sign and finally making it through a very difficult course of hospitalization. So what about the long-term clinical effects of severe cases with prolonged hospitalization? Well, there can be neurologic deficits, sometimes damage to internal organs, vascular damage requiring amputation, or possible complications. And those who don't have vascular damage in the initial stages of the disease typically experience full recovery. And there's no evidence of chronic disease with Rocky Mountain spotted fever, and no evidence that rickettsia causes a persistent disease state. Okay, what about the diagnosis? So the critical first thing is early recognition. And just even thinking of this, and that maintenance of high index of suspicion hopefully will lead to, number one, empiric treatment with the doxycycline, but also sending serology. A lot of times a recent tick bite won't be part of the history because, as in our case, the patient was unconscious, couldn't give that history, but most times people won't remember. And exposure to areas where the ticks are found and to dogs is probably a more important part of the history taking. Travel history to areas that are endemic is also important. Exposure risk is higher during the spring and summer, but as we saw, it could be transmitted any month of the year. And the diagnosis is usually by serology, but I'll show you as well PCR is part of the story. The standard sera test for Rocky Mountain spotted fever uses the indirect immunofluorescence antibody and antigen. And the assay is performed on paired. You must have both acute and convalescent serum samples, and the recommendation is to collect them 2 weeks apart and to show this fourfold difference to demonstrate seroconversion. And another really important part of diagnostics here is that the antibody titers are frequently negative the first time. So if you're thinking of it and they're just coming into the ICU, they may not have developed antibodies sufficient to detect, but don't let that dissuade you from offering doxycycline. That's critical, or from doing a follow-up test to see if there's a change, bump up in the titers. It can't be, the diagnosis cannot be confirmed using just a single antibody test, and that's why this sequence showing the fourfold seroconversion is critical for cinching the diagnosis. The other test, which is super important now, is sending a PCR. So that is done on whole blood, and rickettsia infect the endothelial cells, as we saw in an earlier picture, that line the blood vessels, and it doesn't circulate in large numbers in the blood until it's in a very severe or advanced stage. And although a positive PCR result is helpful, a negative result should not rule out the diagnosis, especially if it's done in the first week or so. PCR also might be used to amplify the DNA obtained from a skin biopsy or from a rash lesion, or also could be done on postmortem tissue specimens. So this summarizes the diagnostic advantages of each PCR and the immune testing. So timing is critical, and persistence of consideration for this diagnosis is also helpful to make the diagnosis. So other labs, normal white count is often observed early on. Later, in a lot of tick-borne diseases, thrombocytopenia can be a prominent feature. So think tick-borne diseases with vascular injury if there's thrombocytopenia. DIC is rare. Hyponatremia and elevated transaminases is also observed. About a fifth of the patients have an elevated creatinine, and a lumbar puncture, often obtained because of the initial presentation of terrible headache, fever, and rash, can generally, with Rocky Mountain spotted fever, will show a white count less than 100, and it's dominance with PMNs and mononuclear cells. And the protein level, 100 to 200, is observed, and often a normal glucose. So it's not really suggestive of an obvious bacterial meningitis, but if it looks to be like this profile, think outside the box and think of Rocky Mountain spotted fever. So what about the treatment? Well, the critical first thing is antibiotics, and early treatment with the tetracycline or doxycycline is critical, and should be offered before a diagnosis is made. Just when if you think of it, considering this diagnosis, get the doxy going. The other part of the care is supportive, so fluid management and pain control. This is a table of treatment. Really, the only thing you need to know is doxycycline. And let me just make a few points. The standard dose is 100 milligrams twice daily. If they're vomiting, you could give it IV. The duration is usually only 5 to 7 days after the fever resolves, so total of 7 to 10 days is a usual course for this very severe and possibly fatal disease. Renal dosing adjustment isn't necessary. Pediatric dosing is listed here so that if the kid weighs less than 45 kilograms, it could be dose adjusted downward. And obviously with pregnancy, it's a consideration. There are alternatives such as chloramphenicol, one of the antibiotics originally used, or even azithromycin to avoid the teratogenicity of pregnancy. And another point, lastly, to make about allergy is if it's somebody has an allergy to doxycycline, that's not an absolute contraindication to its use. I, for instance, have an allergy against doxycycline when taking it for malaria prophylaxis years ago, and several repeated times have a fixed drug reaction, which is the typical type of doxycycline allergy. But that shouldn't preclude its use in the situation where Rocky Mountain spotted fever is being suspected, because the cost analysis of death versus a uncomfortable rash from a fixed drug reaction are vastly different, and hopefully that doxy would be offered in the face of an allergy. Okay, and lastly, just to talk briefly about prevention, tick removal is critical, and this is the technique, grabbing the tick with a tweezer at the base where it's embedded in the tissue, and trying not to crush the tick as you remove it, and then preserving it and sending it for analysis to understand what kind of tick and therefore which tick-borne disease could potentially be transmitted is also important with respect to prevention. And then personal protection measures. This is a study looking at what people actually did, and there's a lot of opportunity here for improvement, because people don't often think of wearing protective clothing or showering or bathing or looking for ticks afterwards, or even using repellents, but they are very effective. And if you wear permethrin or apply DEET, that can be useful for avoidance of ticks, especially if this is a regular exposure or you live in an endemic area. And then lastly, protecting your pets against ticks using a collar, checking for ticks, and being aware that dog ticks can transmit this, and trying to avoid getting them from dogs to humans. So in summary, Rocky Mountain spotted fever is caused by Rickettsia rickettsii. It's associated with 3 different ticks, mostly dermacenters in the US, but also Rhipicephalus ticks, and data showed that from 2011 to 2019, 57% of reported cases presented with serious illness requiring hospitalization. So if that happens, think doxy, use doxy. empirically. It's got a 7% mortality, and if untreated, 25% case fatality rates are observed. And it's difficult to recognize or think of it because it's a very non-specific clinical presentation, but test for it if you think of it. And epidemiology in the US, even though it's called Rocky Mountain spotted fever, it's not in the Rockies as much as the Southeast US. Presentation is similar to meningitis, so fever, headache, rash, and severe illness can ensue. And consider it all at-risk people, especially during the season, but it could happen any time of year. Again, the treatment is doxycycline, and prevention involves tick checks and use of preventive strategies. Here are some references and some acknowledgements. I'd like to thank the patient for sharing his experience, and Eric Foster from the Vector-Borne Disease Division in Fort Collins, Colorado, the CDC, for sharing his information with us today. Thank you very much.